Well, welcome everybody to our AGM this year. It's unusual circumstances, of course, doing it remotely like this. Not our usual way of doing things, but this is obviously the life much of us are leading now. So welcome all. Thanks for joining us. So I should introduce myself. I'm Mark Ricketts, GP, Chair of the City Hackney CCG, for those who don't know me. Today joined on our panel David Mayer, Managing Director of the CCG, Jane Milligan, the Accountable Officer, Henry Black, Chief Finance Officer, and finally Catherine McAdam, who's Associate Member at CCG for Equality, Diversity and Sustainability. I should just say the session's been recorded and will be available on CCG website in a few days' time for those who want to see it again. So next slide. Actually, I'm not seeing any slides, actually.
I'm sharing your screen. I'm sharing the screen now.
Super. Thank you, Curtis. I was just going to go to the slide, which is the agenda. There we are. There's the gallery I've just described. So we're going to go through the agenda. I'm starting, and then a little bit of a sort of background overview from myself. Then we'll be have a spotlight on equalities and sustainability that Catherine's going to lead us through. And as you can see, we'll pass from one to another, and then hopefully, without talking for too long, because we only do have an hour today, we'll have some time for some questions from yourselves. So next slide, please. So I should say, you know, like the rest of the NHS, faced with unprecedented challenges and changes the way we work and we respond. We will report on some of this as we go along in terms of the COVID response. Clearly, the AGM relates to the year ending March 31st this year, which was early in the pandemic, but it seems ridiculous not to acknowledge it in today's session. But I think one of the reasons all the work that preceded the pandemic hitting us, our response and our ability to respond across health and social care was actually massively enhanced by all the work that's been going on with developing our relationships between our partner organisations over the last year or two. And I think it's held us in good stead, very good stead. And the future, you know, lots of very positive things have come about because of the need to change the way we work and working more together in different ways. And some of those things are really positive, and we want to make sure that we maintain those, particularly for the, the positive changes for our staff well-being, and also always, as ever, looking out for those whose outcomes are not as good as everyone else's. Tackling health inequalities continues and will remain our overriding priority. And we know that COVID shone a light on some of that work, and we need to really keep our eyes focused on that. I also want to just say a thank you, essentially, for the outstanding and, in some cases, pioneering care that staff and public and volunteers delivered at the height of the pandemic, and continuing to deliver. And actually the work that we continue to meet the needs of non-COVID related health and care needs in the context, doing that safely in the context of COVID being with us. The fight's not over, and there are likely to be more tough times ahead, but I do want to reiterate the thanks to all those who have really stepped up and done fantastic work. But we also have to acknowledge, and I want to, sadly, some of our colleagues and families who worked, primary care, trusts, local authorities, voluntary sector, have made unimaginable sacrifices during this time. And I would like to acknowledge the staff and the residents who have lost their lives during this time. I think it's important that we, to you and to all our local communities, we send our heartfelt condolences for these sacrifices and these losses. And I would like us to just take a moment, actually, just to stop and have a moment of pause to think about them. Thank you. So I'll continue. Next slide, please, Curtis. You can see this is a snapshot, as usual, of our annual report. There's a great deal more information in it. There's the link to it. It will be on the website, and indeed those people who have logged onto the call will also receive a link to it as well, so they can read it at their leisure. Next slide, please. I'm going to move on fairly quickly now. So we are aware of our population and the challenges that we still face. Those figures for the population of residents in Hackney and in the city, and the numbers registered with GPs locally. I mean, the city has 400,000 people come and go each day to work, all manner of challenges. And I think that 90 languages spoken it still resonates with me as an extraordinary illustration of the diversity of the population across the city in Hackney. Next slide, please, Curtis. The significant challenges. We still have high mortality rates for preventable diseases, smoking, diet, inactivity, high levels of deprivation. These challenges continue, and we see them in terms of higher than expected rates of death, for example, from cardiovascular disease. We also see it in some of the kind of markers of potential ill health in the future. So it says 40% of school pupils, that's 40% of children in the year 6 of primary school are either overweight or obese. We know that people will present with long-term conditions such as those listed earlier in life when they are faced with living with a situation of deprivation. And we know that we have high numbers of people living locally with mental health conditions. So significant challenges continue. Next slide, please. So I want to just illustrate some of the points from our report. But before I mention some of the highlights on the slide, it is worth just stopping to reflect on the fact that the CQC will go around rating the effectiveness of organizations. I mean, I know it's not the only measure that counts, but it does have legitimacy and it is important. And we are, I don't know of anywhere else in the country which has a CCG that's rated outstanding. A hospital trust actually that went to outstanding this year, actually not the year we're talking about, but they are now rated outstanding. And of course, they run many of the community services. And we continue to have a mental health services run by East London Foundation Trust, also rated as outstanding, which is terrific, really. But going on to some of the slides and some of the highlights there, well, I should say much of the achievements we're going to describe are based on the fact the ways we go about our work in City and Hackney, and the fact that we have always held dear the sort of, we call the sort of triumphant model of a clinician, a manager, and a member of the public, as much as possible, working together, whether it's working on a pathway of care or a policy or whatever else it might be, and seeing the public voice throughout our organization and trying to, as best we can, co-create what we do by bringing people with us as much as we can. And I know that there's always a challenge about that, and we could always try and do more, but I think we've got a good track record of that. And I think many of these achievements are testimony to that way of working. So I don't propose reading them all out. I'm sort of speaking to you, can read them as we go along. But I think that, for example, you know, a virtual fracture clinic, use of technology, when you've recently fractured a limb, before you get anywhere near rehab and the plaster cast is still in situ, most of the time the orthopedic person would just want to know whether those bones are knitting together. They don't necessarily need to have you sitting for 3 hours in a waiting room waiting to be told, yeah, they're going all right, well done, come back and see me in a month's time and we'll see if we can take the cast off. This stuff can be done much better in other ways. We've got obviously virtual video appointments, and a lot of that is that Attend Anywhere is Acute Trust's video platform they use, and there's lots of work, and certainly since COVID hit us, that's just spread out massively across primary care as well. I've highlighted a number of others, but I'm aware of the time, so I'm just going to move on to the next slide because there are some terrific things we could say here. Cancer, diagnosing cancer earlier. It's so important, and we've got some great outcomes there. Achievements for unplanned care. The remarkable performance of A&E in Homerton continues. I know it's a kind of a system achievement because of getting, care before you go to A&E and getting people through the system and out of hospital as well. But nonetheless, what goes on in that A&E department and across the hospital is terrific. It's really, really fantastic. We've got our neighbourhoods and our neighbourhood model of working, and we will speak and increasingly about that and how important it is to get that key unit of planning and delivery right. And we've got GP primary care networks feeding into that now, a lot of transformative work going into that way of working. But also lots of other initiatives, that high intensity user, for people who may engage with urgent care, 111, 999, A&E, several times a month, a bespoke offer to help them manage some of the reasons more holistically as to what drives them into seeking emergency care when actually care can be delivered in a much better way to support them. Again, I think we need to move on to the next slide. I'm aware of time, lots of other things we can say, but it is in the report. So prevention, the top performing CCG in England for 10 measures of clinical care around things like those people who've got diabetes having good blood pressure control. And that's good, because that means ultimately they are less likely to have some a problem down the line, like a stroke, heart disease, etc., etc. Our social prescribing service, again, has won an award, Best Large Social Prescribing Service in some UK, or I think England awards last year. Wonderful. And again, looking to reach into more preventative work, wider determinants of care and healthcare needs work. This low energy diet pilot, for those for whom it can work, loss of weight can put diabetes into remission. And that has been shown in research areas, but now we're showing it in real life clinical environments. And the pilot has certainly started to support what can be done in that way. And that's something obviously we would want to invest in and develop further. Group consultations, an interesting way of working as well. But again, I'm going to move on to the next one, Curtis. Children and young people, lots more support going into schools for supporting the mental health of children. And indeed, never was it more important at the moment with COVID, with so many children not being at school, and how those mental health needs can be addressed. Well, now they're back at school, thankfully, for many very good reasons. But now, of course, those who need it can get support through these sorts of systems again. And that's something we're expanding and rolling out. And you can see a new initiative we set up for the health of looked after children who are in care, a particular area we realized we needed to do more on, and something was put together, a service was put together this last year, which has been really, really valuable. Good, and I see there's some highlights as well around maternity in early years, around the care of women who are pregnant. And actually you can see the very bottom one again, using best evidence of clinical care, women receiving magnesium sulfate reduces the risk of cerebral palsy and in preterm babies. So 100%, great, they all get it now, which is terrific. But we didn't know that the magnesium did that until fairly recently, and now we do, and now we've got a service that delivers it. I think it's really good stuff. So moving on to the next one, mental health, improving access to psychological therapies, psychological support. In fact, the recovery rates and the evidence of those psychological inputs benefiting people are very strong across City and Hackney. And there's been a lot of work in the year that we're reporting on expanding those services. People who suffer with serious mental illness, often their physical health care traditionally has been much poorer than for those who don't suffer with physical illness. And we've managed to get a service which supports people's physical health and has a big impact in terms of other prevention of other illness they would otherwise suffer. And it's rather nice to see that won a national award for that work. And it was very much a work that brought different providers together as part of our Mental Health Alliance. And I think it's great to see these things are so much dependent on people working together, coming together and doing things better together. Again, you can read the last two, but I feel like I need to probably stop because I think I've probably gone on long enough, and we do want to have time for our questions. So before I hand over to Catherine McAdam, who will be talking on the inequality sustainability, I just want to repeat my thanks to the work patients and public reps do in terms of their work with us at the CCG. This PPI, this involvement is so valuable, and indeed also has been rated outstanding by the regulators. Again, I've alluded to the fact it's so important to support, underpin the achievements I've just been describing, and continues to and will continue to be the case as we move forward into the future. So one thing which is different this month, this year about our AGM, we usually have a workshop which follows, and we can't do that this year. But I just wanted to highlight there will be a big workshop in October dedicated to a PPI engagement event. There'll be more publicity about that down the track. So this illustrates that although we've lost an opportunity today, we intend to make up in the future to keep going with our work, engaging with the people and the population we serve. So thank you. I think that's enough for me. Catherine, properly now, over to you.
Okay. Hello, everybody. I'm sure most of you know me, but my name's Catherine McAdam, and as Mark said, I'm the lay board member with responsibility for equalities and development and equalities, diversity and sustainable development. And my role as a lay member is to offer an independent perspective, to scrutinise, support and challenge decision-making in the CCG, and to work with staff, clinicians and my other board member colleagues to support this work. So the role I'm in is a new role, and it was created a year ago. So I just wanted to reflect a bit on what I've learnt in the time that I've been doing this. So the work that we've just been hearing about is all focused really on creating a sustainable health and care system for City and Hackney. And I am reassured that underlying all of this, there is a clear understanding that such a system can only be sustainable if it addresses and seeks to deliver equal access to health services, but also equal health outcomes for everyone who lives here. And as Mark alluded, I think we have, as a history, we have a long, as a CTG, we have a long history and a wealth of clinical and other experience of tackling the impacts of inequality, particularly poverty and economic inequality. And the work we've been doing already was given a new impetus when the coronavirus pandemic hit, and further focus again by the global Black Lives Matter campaign. So as the disproportionate impact of COVID-19 on particular groups of people became clear, we've been working together as a system to try and properly understand what this impact has been locally for people of City and Hackney. We've also had to recognise that however much we were doing before, it was not enough, and change is needed if we're going to be able to address the fundamental inequalities in health and well-being that COVID has highlighted. Many of which we have to acknowledge existed and were known about previously. So the initial response to the pandemic was, of course, of necessity fast and pragmatic, and it was really focused on saving lives. But now we find ourselves in what's been called restoration and recovery phase. And now I think the urgent need is to make sure that any further changes that are made are done with a clear eye on how these changes will both address the inequalities we've seen, but also ensure that they are not made worse or exacerbated any further. So we know from our conversations over the last few months with the people and communities of City and Hackney that trust in systems and trust in institutions has been damaged by the experiences of both COVID-19 and the spotlight that Black Lives Matter has shone. So for the CCG, as it moves forward into working as a system partner in City and Hackney and across North East London, I think it's absolutely a priority to rebuild that trust, not just by trying harder, but by working differently. And this will mean breaking down artificial and unhelpful barriers, moving more quickly to multidisciplinary working, focusing on neighbourhood populations, and finding new and better ways to work with and be led by our patients and residents and hear their views and challenges. I'm sure that by recognising the urgency of this work and applying our collective passion, good communication, and refusing to play blame games, that we can overcome these challenges. Our Sustainable Development Plan, which we will be talking to you more about in the coming months, will be an important way of making sure that the commitment to develop an integrated health and care system that builds on positive relationships and tackles the inequalities, that these commitments are honoured by focusing, for example, on issues such as climate change, social environmental improvements, development of our voluntary and community sector, together with employment opportunities for local people to contribute to and lead these changes. So over the next 6 months, it'll be my priority, together with my governing body colleagues, with staff and clinicians, to make sure that when we do meet again, we are able to demonstrate how these commitments have been translated into actions and outcomes that are clear and visible to everyone. Thank you.
Great. Thank you, Catherine. Shall I pass the baton to David? Thank you very much, Catherine. And we'll see if you get any questions up in the Q&A as we go along. But we're going to take all the presentations first. David.
Thanks, Mark, and hello, colleagues. So I'm just going to cover some of our plans looking forward to developing our integrated care partnership in City and Hackney. You'll be aware that we were a devolution site looking to take further local control over our services within City and Hackney in 2016. And we've continued that culture of getting as much resources under local control across the partnership within the local authorities and the CCG, and that work continues. I think we're at the next step of thinking about what that means in actual getting services delivered for our residents, and we've got a proposal that has been mentioned around neighbourhoods, which has been in place for some time. So we continue to work on building those neighbourhoods with our primary care networks at the heart of those, with a proposal that we would begin to have a neighbourhood health and care board, which would help us drive those improvements at a very local level. This, of course, will involve our patients, providers, and all staff as equal partners. And I think the real magic in that is that by bringing our mental health, primary care, acute services, social care, and other parts of the local authority together, we think we stand the best chance of tackling some of those inequalities that Mark referenced in his opening slides, that are really entrenched in some parts of our locality. So the next slide talks about what we're trying to achieve through that. We're trying to get clearly better support for patients and their families to get healthy and be as independent as possible. We think that that support is best gathered at a very local level with our voluntary sector partners. And we think that by working together with patients, we stand the best chance of doing the things that matter most to them. So that more support is very much a co-produced ambition. Neighbourhoods are the framework around which we're designing services. So we're looking to get really hyper-local with the work that we do, getting right alongside local communities at population levels of up to 30 or 50,000. We currently have 8 neighbourhoods working in that way. And they really understand their local needs and are able to communicate back to us the things that need changing and help us focus on some of the other opportunities around our role as an anchor system in City and Hackney, about how we might build resources better in local communities where deprivation remains a challenge. Joined up support is something our patients have told us repeatedly is one of the missing ingredients in some of the great work that we're already doing in City and Hackney. There's good joined up work, but there's more we can do, so that people that don't have to tell their story more than once, and that we don't have any wrong doors. We're able to navigate and support people to the care that they need at the time that they need it. Mark talked about our outstanding performance across a number of areas. We've also have a rich heritage of outstanding and great GP practices, pharmacists and community support, providing close, really close to people's homes. We've seen this exemplified during COVID, where we've had doorstep assessment services in place and a much more mobile response from our primary care community, who've really done an enormous and well acknowledged job in keeping our residents safe and well, and we thank them for that. And then, of course, we wouldn't be a thriving system without having access to good, thriving local hospital services, and our work with Alft and Homerton is pretty critical to this. We think that the more work we can do with our local hospital, beginning to build those neighbourhoods where services begin to move much closer to people's homes, is a really important opportunity in the next phase of our working as an integrated care partnership. So the final slide for the section I'm going to speak to relates to just an illustration of how we're trying to organise ourselves for this. So we obviously have a strong heritage of co-production in City and Hackney, so our patients and our communities are at the very top and central to our thinking. I've talked about neighbourhoods being the way we are trying to organise health services. They are distributed across 8 primary care networks, who are our local clinical leaders who are driving health improvements within primary care networks, and they're very solidly part of the future way of how we're going to support our patients in the next chapter of our work together. A key feature of the model for integrated care is, of course, things are integrated, so people need to come together and work together. So you see in the green box all of our partners: the City of London, foundation trusts, the GP Confederation, primary care networks, but also other elements of the system such as housing, advice, police, those things that people access and have challenges with on a daily basis are things that we think by working closer together we can improve their outcomes and improve their health. There's a set of major programs which are in development as part of COVID. So we've been organising our work into 3 big categories around rehabilitation and independence, neighbourhoods and communities, and children, young people, maternity and families, critically, being part of a very focused way of working in an integrated way, supported by primary care, good IT services, and planning on estates. How we're planning on organising those programs is under a neighbourhood health and care board, which will be very much the board that is responsible for driving delivery at a local level and making those improvements real for local people. And it'll be supported in its work by an integrated care partnership board, where some of the statutory responsibilities for our commissioning responsibilities will sit within that board, but we will work alongside our partners to help shape our decisions and get to a position where we're planning for population health in a true partnership way. So that's all I was going to say on that, Mark. And I think at this point I'm asking Jane if she'll be able to give us an outline on how this fits into the priorities for looking forward.
Right, thank you, David. So for those people who don't know me, my name's Jane Milligan, and I'm the Accountable Officer for the 7 CCGs in North East London, and I also act as the Executive Lead for the STP. So thank you very much, and great to be here. As I say, our first virtual City and Hackney AGM. Before I continue though, I suppose I'd like to echo what Dr. Ricketts said in relation to really acknowledging the impact that COVID has had, and offer my condolences to people who have been affected by the loss of life in COVID, but actually generally, acknowledging that I think we've all been affected in some way by COVID. And whilst we're here to discuss the last financial year and highlighting the key achievements, which I think Mark has done incredibly well, I suppose it's really important to acknowledge, as I say, the sort of difficult and challenging 6 months that we've had, not just in the NHS, but throughout our communities. And to really, I suppose, acknowledge again the incredible teamwork and amazing resilience people have shown to really respond. And I would like to personally thank everyone for all their hard work in addressing the pandemic, and thanking not just our staff, but actually also our communities and patients too. So in terms of priorities for next year or for 2021, I mean, I think it's key to say, obviously COVID shapes that, and really key priorities, it still remains very much at this moment in time about preventing infection spreading, maintaining the safety of our patients and staff, and building and maintaining sufficient capacity to be able to respond to both business as usual and catching up on some of the impacts that we've had to, has happened as a result of COVID, but actually also responding to COVID waves as they go forward. But more importantly, as in terms of caring for our most vulnerable communities and people, and acknowledging that's going to be and is within a very tight financial envelope, both in health, but actually also in social care and the local authority. So as I say, our priorities will inevitably be shaped by COVID response and ongoing management of the pandemic. But I think, as David said, and we really need to continue to work on how we have been working in developing our partnerships at a neighbourhood level, and that really being part of the founding blocks of then how we do business across North East London. I think essentially our focus will be about restoring, and is about restoring, services that have been impacted by COVID, such as elective care, cancer and diagnostic care, but actually also continuing to do the fantastic work that's happened in relation to really working collectively together to deliver primary care, mental health and community care, and particularly working with our communities and voluntary sector. At the moment, we're currently submitting operating plans, which has asked us to respond to the next phase, or phase 3 of COVID. But actually there's also an emphasis not just on that, but actually how we do, as Catherine has said, really focus on our work in relation to health inequalities, and also about how we develop and work with our people and our people plan. As part of our learning from this and part of how we are developing that plan, we've been working very closely with health watches, both across North East London and in particular with the City of London and Hackney, in making sure we do as much as we can to gather insights on people's experience over the last 6 months, so we actually build that into our plans. So for example, working with some local youth groups, particularly about the impact they've been feeling, particularly in relation to their mental health and well-being. And actually, as I say, part of our plans do include specific plans in relation to areas such as mental health. So we need to do more of that, and we need to reflect people's experience as we, again, continue to co-create our response. Again, Catherine's already outlined the incredible work that's happened as a system in City and Hackney around health inequalities. And as I say, this is really has been brought to light as part of COVID and really exposed the area and the work we still need to do. Again, a lot of that does need to happen at a very local level, but I think we also recognise there's a great opportunity for us to work together. So this week we had a fantastically well-attended event looking at anchor institutes and anchor systems, really sharing good practice and ideas about how we do that at scale, where it means that we can actually manage up and ask nationally some of the key sort of initiatives be part of our plans. So for example, how we use apprenticeship schemes for both young and old, and Kickstart as another example. Again, building on David's presentation about the Integrated Care Partnership in City and Hackney, I would like to just talk through briefly about what our plans are for the integrated care system that is North East London, and as part of that, our plans in relation to the single CCG. So for those of you who can remember before Christmas, which is quite challenging at the moment, there was the long-term plan published and we had to respond to that. Part of that was an outline of a requirement to us to strengthen our current partnership working and our East London Health and Care System, our STP, and actually be working towards the development of an integrated care system for April 2021. Part of that was the appointment of Marie Gabriel, who in April was appointed as our independent chair. And I know many of you know her and have met her as she is a long-standing member of the infrastructure almost of North East London. Again, I think David's made the reference that we've talked a lot about integrating care and services over many years. And actually in many respects, the COVID and the COVID response has enabled us to really focus on actually and speeding up our ability to respond in an integrated way. So focusing on, as I say, people's joint accountability to focusing on our response to the pandemic, as I say, working across organisations and the GP Federation, the Homerton Primary Care Networks, and working with our local authorities in the City of London, as well as primary care, to really focus on that. And we actually are starting to join up, working as commissioners and providers in a way that we haven't done for many years, breaking down some of the silos and some of the unintended consequences, perhaps, that have been part of some of the previous health policy. We've also been working across with providers, have been working and forming alliances across organisations to respond to the infection control requirements, but actually deliver care, really addressing some of the workforce gaps and skill gaps and skills gaps, but actually also working mutually to deliver what we have needed to do to actually ensure we provide that safe care for staff and patients. And again, certainly in relation to primary care and primary care collaboration, working with the development of the PCNs and the GP Confederation, again, we've also delivered an excellent response to protecting and delivering care for our most vulnerable patients and people, especially in care homes. And that still remains a continued priority for us. The development of the ICS, or Integrated Care System, does though require us, I think, to work, the opportunity requires us to work differently in commissioning. And as part of that, we've been engaging members, GP members, about what that would look like as part of the development of a single CCG to be implemented ideally by April 2021. That really aims to reduce a lot of bureaucracy, perhaps, that 7 CCGs have developed in isolation, working separately, but actually also means that we can release people and resources and skills to really concentrate on delivering at neighbourhood and neighbourhood level. So we've got more to do with that, and we are engaging with our GP members on that, and we'll continue to engage with all of you on how we develop the integrated care system, looking to provide something in shadow form before Christmas. But I suppose there is a very specific principle that we're working on, which is essentially 80% of care and 80% of the resources, and in fact, actually it's more than that, is very much part of and is delegated or is actually at a local level. And I'm sure Henry will talk about that later in a minute. And only where it's important or anywhere it makes sense do we do things across North East London. So for example, it might be in relation to delivery of specific campaigns such as the winter flu programme, or actually setting standards in relation to how we want care to be delivered in the areas of primary care or maternity care. So the next steps for us really will be, as you say, continuing to respond to COVID and implementing our phase 3 plan, but actually also continue to engage with our communities and locally co-produce our response to that and beyond. Certainly more work to be done, and certainly more work to be done in terms of making sure we're reaching out to all of our communities going forward. So I think I'm going to hand over to Henry now, so thank you very much.
Thank you, Jane. Henry.
Thank you, Jane, and thank you, Mark. And hello, everybody. My name's Henry Black. I'm the Chief Finance Officer for the CCG, and I'm also the Chief Finance Officer for all 7 CCGs in North East London. So I'm here today to present the financial accounts for the year 2019-20. So that's from April 2019 to March of this year, and to set out the financial performance of the CCG. So the CCG hit all of its financial targets for the year 1920, and NHS England set a number of targets for the CCG to hit. Those include staying within the expenditure of against the allocation, so not overspending the allocation for clinical services. And in addition to that, we receive a separate management cost allowance for our corporate costs. And we hit both of those targets. Within that, we actually delivered an overall surplus of £2 million, and that £2 million was largely made up of an underspend against our management cost allowance. So by underspending our management cost allowance and having a lean corporate structure, we were able to reinvest that money into frontline services. Every year we are scrutinised by the external auditors, so our annual accounts are subject to an external audit. The auditors gave us a clean bill of health on that, so we received a completely clean and unqualified opinion. So unqualified simply means that there was nothing in the accounts that they disagreed with. So the accounts were approved in terms of regularity as well as accuracy and value for money. In addition to that, throughout the year we have internal auditors who do a more kind of thorough ongoing review of our internal processes around financial planning and reporting. And we received a green RAG rating with substantial assurance for all of those internal audit functions. The CCG also delivered £5 million of recurrent efficiency savings, and that money was reinvested back into the front line, and it enabled us to invest 4.4 million of additional investment into enhancing a programme of services around enhanced quality and access to person-centred care. Next slide, please, Curtis. Thank you. So my second slide gives a bit more of a kind of illustration of where exactly we spend our money. So you can see from that large pie chart that the biggest slice of the pie that we spend is obviously in hospital services. So the large blue quadrant at the top is the Homerton. So that was around about £120 million that we spend with the Homerton, and a further £80 million on other hospital services. We also spend around £13 million on ambulance services, about £50 million on mental health, £40 million on community services, and around about nearly £50 million on primary care services. So that's the breakdown of where we spend our money and the overall financial performance, which is good for this financial year as well. Finally, we have a few other small minor technical financial targets that we have to hit. They are largely around management of cash and the way that we pay our suppliers, so that we have a public sector payment performance targets, which in other words means we have to pay all of our suppliers within 30 days, and we're required to hit those targets according to value and number of invoices, and we hit both of those targets. So that's all from me. I think I'm handing back now to Mark for the Q&A.
Thank you, Henry. In terms of the Q&A, I'll bring you in on one financial one in a moment. But first, I'm going to just turn to a question Malcolm Alexander has posted, which has just disappeared from in front of me because I was about to read it out.
Sorry, I've answered it.
I know, I'm sure you have, David, because I was going to turn to you to answer it, but actually it was essentially in relation to the development of the neighbourhoods and the public involvement in that, and how that's been involved in shaping their offer. Do you want to just articulate that out loud so that we can cover that? Because I'm sure others will be interested in that.
Yeah, thanks, Malcolm, for your question. We did quite an extensive piece of work with our communities last year, and the year before, indeed, on developing a set of I statements. So what people want to see in their local services and what they want to see happen within neighbourhoods. So I shall make sure those are recirculated in summary documentation that we send out after this meeting. And then the neighbourhood teams themselves have quite extensive local engagement processes in place through the neighbourhoods to capture resident involvement in that. That's pretty central to the model. But if you haven't seen evidence of that, then I need to get it for you, and I will.
Thank you, David. Can I go back to you, Henry? There was a question which we received in advance, which I'm sure lots of people will be interested to hear you, because a clear narrative to give, which was around how will the budgets at NEL level be managed and devolved to local systems? Will City and Hackney continue to receive the same amount of funding?
Okay, so I will, I mean, to give people assurance, the short answer to that is yes, absolutely. But I will answer that in kind of two ways. So firstly, as part of putting the financial framework together for a proposal for a single CCG, we've made a number of pledges. One of those pledges is that no CCG in its current form will be worse off, will be made worse off by the merger. So as people will probably understand, that at the moment, as a separate CCG, City and Hackney receives an allocation directly from the government, and all 7 CCGs in North East London receive their own separate allocation. If we decide to merge, the single North East London CCG will receive that total allocation on behalf of all 7 boroughs, and will then delegate that money down. And the pledge, the first pledge that we've made is that that we will use the previously published allocations going forward for the next 4 years as the basis for setting the budget. So what that means is we will effectively ring fence the same amount of money that each CCG would have had the merger not happened, and we will delegate that amount down as the borough-based budget. So that's the first pledge. The second pledge is that we will only create a very, very lean and very, very small amount of resource held at the North East London level. So Jane talked earlier about the 80-20 principle, in which 80% of decisions will be made locally. In actual fact, 80-20 is kind of used as a bit of a kind of indicative figure, but when it comes to the finances, we will actually be delegating between 97 and 98% of the budget down to the local level. Only a very, very small amount of money, 1 to 2%, will be held centrally, and that will just be to pay for the kind of central management costs, of which there are very, very few, very small number of people, and a 1% reserve or risk share that will be held centrally in exactly the same way as has in fact been the case for the last 4 years, or with the 7 CCGs working independently. So that's rather a long way of answering the question. Yes.
Thank you, Henry. I think it needs a bit more detail though, so I appreciate that, because a simple yes is good, but people want to hear a bit about the background, you know, what's behind that. So thank you for that. I'll pick up a question now. There's a question we've come in about a question on digital first and how we will ensure those who aren't online are getting the same quality of service and their voices heard in decision making. Yes, I think certainly there are lots of ways of interpreting that, but certainly, for example, when it comes to primary care and some of the narrative around digital by default, which was sort of discussed sort of nationally, we were always a bit uncomfortable with that, and we always kind of tended to just use the phrase digital where appropriate. You know, practices are open. You can still knock on the door and ring the bell, etc. You can ring, you can telephone. There are other ways of accessing, say, primary care. Some practices actually do now ask everyone to fill in an online form, and that goes to the doctor before the doctor then rings them back. I'm in a practice like that, and anyone who struggles to speak English or is having difficulties with that, the receptionists have now we've freed up the time for them to fill in those forms for the people. And if there's an ongoing problem, then the person just gets routed through the good old-fashioned way. So there are lots and lots of checks always to test ourselves against, you know, any initiative. How is this fair? How would I access this service if I didn't speak English? How would I access it if I was blind? How would I do it if I was homeless? And it's a set of kind of checks that we do bring to bear whenever we're thinking of issues that might sort of further entrench existing inequalities or give opportunities for new inequalities to develop. And that's absolutely not what we want to do. And having people keeping asking questions like that and poking us and saying, "Are you sure?" is entirely, well, welcomed. I mean, I use the poke lightly because, you know, I hope you know what I mean. We value that challenge. So I hope that's helpful. To answer the question more thoroughly, you'd have to have a very long discussion about how you get into, you know, outpatients and elective care, etc., etc. One other other thing I was going to say about the money and the ICS is we also have a phrase where the integrated care system at North East London to thrive, the local systems have to thrive. They're absolutely, the success of each is completely mutually interdependent. And that's also a thing that we know we have to do. And indeed, at the North East London level, we are working together to have a set of principles which we will use to test ourselves against, in the same way as I just described a bit about the equalities piece, to make sure that we are keeping on track with what we're trying to do. Shall I turn another question. I can't see, there's another one in the Q&A. Let me just have a quick look at that, because there was another question, another financial one. Henry, do you want to just have a look at that? It's from Shirley Murgraff, and just pick it up in a second. Before going to that one, we've got enough time to bring Jane in, I think. A question which came in earlier, which is, in view of recent changes to elective provision, when will the CCG be moving to public engagement before changes are made to services? I know this is very difficult because much of what's happening with elective provision is responding to standing up services safely with infection prevention and control in the light of living with COVID, and also safely not only for preventing infection spread, but also keeping the staff safe as well as who manage patients. It is also in the context of being under emergency powers because of the COVID legislation that's been passed. But nonetheless, there are changes, and how do we best, bearing in mind those sort of rocks and hard places, we still want to try to engage people as much as possible now, and certainly as we move into the future. So Jane, would you like to share some thoughts about patient and public involvement?
Yeah, no, thank you, Mark. Thank you, Mark. Yeah, so I suppose, again, just to reiterate, and to reassure people, no permanent changes will be made without any due process and consultation, and also equalities analysis. So I just want to make that statement very clear. As you said, I think I made reference to the fact that the Homerton colleagues, Barts Health, and also BHIUT are working collectively to work out how to safely respond to the national requirements, which do change quite regularly in relation to infection and control. And actually making sure that we've got areas within each of the hospital sites that are essentially COVID-free, or as much as possible. And so some areas of what's called high volume, low complexity, so things such as hernia operations or gallbladder operations or single joint operations, we actually work out the best place for those to be delivered, perhaps for a slightly wider population, but for a short period of time in response to, and as a temporary measure into the COVID. So for example, utilising some of the capacity that actually we have within the Gateway Centre, which is in Newham, which actually provides hip replacements already for a wide population. But actually looking to see, again, keeping that as a sort of a COVID-free centre, which would continue to provide, or could provide, extra appointments and interventions for population or people of City and Hackney. And that's not the pre-operative work or even the post-operative work. That would continue to be very local. But actually also from the Homerton's perspective, utilising their day surgery unit to actually also focus on the simple ENT, ear, nose and throat procedures, as well as some simple surgical procedures. Now it's fair to say we are not yet in a position to have that up and running, and we're just testing that out with staff. But I think certainly over the next 6 to 9 months, because the reality is COVID will be with us going forward, we will be testing that out, and as I say, starting to get people's engagement and response of how the services, or what it's been like for people to undertake those services. But again, just to reiterate, there'll be no permanent changes unless we have to go through due process and consultation and equalities impact assessment to make anything permanent.
Great, thank you, Jane. I pointed to Henry at that finance question, but I think maybe it's better if David picks it up, actually, because it was around the savings that you alluded to, Henry, in the running cost allowance, and the 4.4, which were reinvested from sort of QIP savings, as we call them, which were reinvested. Shirley Murgraff was interested to see a little bit about where they were spent and how much patients were able to shape how they were spent. So that maybe, David, you're a better place to pick that up.
Yes, Mark, I've responded to it.
Yeah, did you want to add anything verbally? So we've got a 5 more minutes we can share with because it may well be a question others would be interested to hear the answer to. In
terms of the development of the ICP?
Well, really, that 4.4 QIP saving and the 1.2 running cost, how was it spent? And how I mean, I think the answer is that it was spent on in things like we spend all the rest of the money on, and everything is shaped by our work with the public and patients. I don't think we could specifically point to an individual initiative that money, like, a hypothecated way, was actually spent on. Would that be right? It was just generally commissioning budgets which went into our work.
Yes. Yeah, it forms the part of our commissioning budget and is then rolled out in the services that you've outlined in the achievement slides. Yeah, I mean, and just to clarify in terms of decision making and process, so all of those developments for business cases and proposals for spending are developed under the triumvirate model that you described of a patient, a manager, and a clinician working up service proposals. As an example, that led to us developing a proposal for personal health budgets in mental health, which was a initiative developed by some of our service users with our mental health team. That's resulted in some excellent feedback from people who've used their personal health budgets during COVID to get a mobile phone and have access to their support worker and keep in contact with support services. So it's those kind of initiatives. And the final thing that I included in my response to Shirley is that our work streams, so the way we organise our services, do very regular detailed reviews of the things that they're doing and the proposals that they are putting in place. And that should be going through PPI committee and others. But we can pick that up as part of the next PPI session.
Great. Thank you, David. And actually illustrating what you just said by referencing mental health services was helpful, because there was a question I know you answered on the Q&A around how patients and public were involved in shaping the services. That's helpful. It's nearly 2 o'clock. But a few actually there are more comments and a thanks from Malcolm for answering his question, and some a nice comment from Tracy Fletcher. So others can read that for themselves in the Q&A. Thank you, Tracy. I think we should wrap up because there aren't any other questions at the moment. It is just approaching 2. It is slightly, as I say, the different circumstances this year. Hopefully we've had a chance to illustrate the work we're doing and take some questions on that. I'm very minded that I think a lot of people on this call are very involved in the work with the CCG, and I certainly hope they continue to be so. And indeed, those who aren't, come on down. We always would welcome more people to get involved. So please think about that. And there are different ways on the CCG website and others to get contacts through and work with. And the PPI group holds the ring on that, and that's obviously a very good way to start. So I'm going to finish by thanking the panelists for their talking to us and their presentations. Thank you very much for your time coming along to listen to this this webinar, and to wish you all the very best in the coming year. And I certainly hope we see you well before 1 year when we come back and do a similar AGM in a year's time. So take care and thanks very much. Cheerio. Bye-bye.
Thank you, Mark.
Thank you, Mark.
Mark.